Hi, and welcome to Introductory Point-of-Care Hepatobiliary Ultrasound. This is Aaran Drake, and I'm one of the GW Emergency Medicine faculty members in the ultrasound section. And I am happy to be virtually attending Intern Ultrasound Bootcamp with you guys, and I hope to be able to see you during the practical sessions. Until we meet in person, I'm going to talk with you guys today a quick bit about hepatobiliary ultrasound. Our objectives for today are to identify patients in whom hepatobiliary ultrasound is indicated, review the physics and knobology applicable to this type of imaging, identify hepatobiliary anatomy with ultrasound, describe the different types of scan techniques we can use for hepatobiliary ultrasound, recognize the pathology including cholelithiasis, cholecystitis, and choledocholithiasis, and then, of course, use appropriate sonographic terminology to talk about our images and form an impression. Here's a quick outline of how we're going to go about today. We'll start with some indications, go over the anatomy, talk about how to get the pictures of the anatomy, really review the 5 binary or yes or no biliary questions that you ask when you perform hepatobiliary ultrasound, go over a few cases. I will have a list of foam resources for you guys to further educate yourselves and get some more practice, and then I've included some questions as like a self-quiz to help you do some review as well. So first and foremost, when do we do a hepatobiliary ultrasound? Whenever you have a patient with any of these symptoms, right, upper quadrant pain, fever, nausea, jaundice, or vomiting, these could all be indicative of pathology like cholelithiasis, cholecystitis, some type of hepatitis, and so using hepatobiliary ultrasound would be indicated at that time. Recall that the gallbladder is a non-fixed organ that sits tucked under the edge of the liver in the right upper quadrant. On one hand, this is fortunate for biliary imaging as the liver is a great acoustic window. But on the other hand, the ribs, which are of high impedance and cast shadows, can sometimes obscure the organ. When we reflect back the liver, we can review that the gallbladder empties through the cystic duct, which joins with the hepatic duct to form the common bile duct, and this eventually empties through the ampulla of Vater into the small intestine. So check out here the very close association of the common bile duct with the hepatic artery and portal vein. These 3 structures make up the portal triad and will be important landmarks in biliary imaging. Additionally, note the proximity of the duodenum to these structures. You will see as we proceed through the images how it can cause us a little bit of difficulty with scanning the organ. The gallbladder has a fundus, a neck, and a body. The neck is especially important to evaluate because stones tend to get lodged here and can cause some trouble once they get there. So, given what you know about ultrasound physics already from your previous lectures, which probe or probes do you think we are going to use to evaluate the liver and gallbladder? If you said the curvilinear or phased array probe, you would be correct. These are both low frequency probes, which means that they provide us good depth, but not necessarily the best resolution. But given the organ's depth in the body, we do need the depth. So again, the curvilinear, which unfortunately we don't have in our department, but you may find elsewhere, or the phased array, which is in the bottom right corner there. So recall that we can scan in multiple different modes depending on the information we'd like to obtain. For the purposes of evaluating the liver and the gallbladder for normal anatomy and for the presence of mass, gallstones, cholecystitis, etc., we will scan in B mode. This is also called 2D mode and is the general grayscale mode. Today we're also going to talk about color Doppler when we evaluate the common bile duct. Here are some general scanning principles that we are going to use to help improve our success with ultrasound. So in general, with many ultrasounds, but especially with hepatobiliary ultrasounds, you're going to want to use a tripod position or the edge of your hand to help anchor yourself to the patient's body. Remember to use plenty of gel. We need to reduce the large impedance mismatch between the air surrounding the body and the soft tissue of the body, so we use a coupling medium, the gel, which allows the ultrasound waves to travel with minimal reflection through the space between the ultrasound and the skin. General scanning principle number 3 is going to be watch the screen, not the patient. So use the landmarks and the structures that you're seeing on the screen to direct the movements of your hand. Oftentimes, people will get caught up watching where their hand is on the patient and they miss the important findings on the screen. General tip number 4, use small, slow, smooth movements. Generally, it's easier to gain perspective and orientation when you move slower. Lastly, correctly expose and position your patient. This is especially important in hepatobiliary imaging. Generally, for liver parenchymal evaluation, we will have our patient supine, but often turning our patient to the left lateral decubitus position is helpful when evaluating the gallbladder, as it allows gravity to help flop the gallbladder close to the abdominal wall and out from underneath the liver. The gallbladder is best seen with at least 4 to 5 hours of fasting and is usually seen at the inferior aspect of the right liver lobe. Moving on to the different types of techniques you can use for hepatobiliary imaging, we will start first with coronal plane evaluation. The choice of technique really depends on the sonographer comfort, patient anatomy, and habitus. This first technique is used primarily for liver parenchymal evaluation, but can be used for biliary evaluation depending on the location of the patient's gallbladder. So to evaluate the liver in the coronal plane, the footprint is placed on the lateral surface of the body and the indicator is towards the patient's head. A small counterclockwise rotation of the indicator may be advantageous to allow the footprint to be positioned between the ribs. With the probe in this position, you'll obtain an image that looks something like this. For orientation, remember that your probe footprint is being placed laterally on the body. Thus, the top of the screen is lateral or superficial, and the bottom of the screen is medial or deep in the body. The probe marker is towards the patient's head, so the left side of the screen is cephalad and the right side of the screen is caudad. As the patient breathes, we can see their hyperechoic diaphragm sliding left and right on the screen. Inferior to the diaphragm, we see a normal appearing liver. It is homogeneous and of medium echo texture. Departure from these characteristics can represent pathology. As the sonographer slides inferiorly along the patient's mid-axillary line, we pass over a rib shadow and then encounter the right kidney. Posteriorly, we can see the hyperechoic spine in longitudinal. While evaluating the parenchyma for normal echogenicity and homogeneity, you may encounter the hepatic and portal veins, which you can see here. On first glance, they may seem indistinguishable, but the hepatic veins have very thin walls, and if you followed them, you would find the IVC. Conversely, the portal veins have echogenic walls, so they are highlighted by bright white edges and branch from the main portal vein. Let's move on to the subcostal sweep. The subcostal sweep technique of evaluating the gallbladder requires that you begin near the epigastrium in the longitudinal plane, meaning the probe marker is towards the patient's head. A sweep or fan is made through the right upper quadrant just under the costal margin in search of the gallbladder. As with the imaging of all structures, we will want to see the gallbladder in two planes, so once identified, we will rotate our probe to the patient's right to change into a transverse plane. There are a lot of great videos on how to perform different exams on the Sonosite website, and I encourage you to use it for reference. Here is just a clip of their biliary how-to video using the subcostal sweep. They start in the epigastrium or just right of the epigastrium with the curvilinear probe in the longitudinal and then begin fanning laterally or rightward. Sweep fully through the liver parenchyma, noting the vasculature. Keep an eye out for hypo or anechoic sac-like structure. In longitudinal, the gallbladder can be long and peanut-shaped, though there is a ton of variation in shape. Note here the presence of the exclamation point sign that the long gallbladder makes with the portal vein. The line of the exclamation point is the gallbladder, while the dot of the exclamation point is the portal vein. Note again that the portal vein has echogenic walls. Often we see the gallbladder and portal vein are connected by a hyperechoic line, the main hepatic fissure, which is an important landmark when the location of the gallbladder is in doubt. The rest of the portal triad is subtle here, but visible within this red circle. We will talk about identification and evaluation of the portal triad components more in depth shortly. The portal vein is the most obvious structure of the triad, and as such we use the exclamation point sign to help identify the location of the triad. Here's another example of the exclamation point sign. The gallbladder in longitudinal and the main lobar fissure is a hyperechoic stripe which connects the gallbladder to the portal vein, which also has hyperechoic walls. One more example of the exclamation point sign. The MLF is shorter in this example, but the hepatic artery and CBD are clearly visible on top of the portal vein. The IVC and spine run longitudinally deep to the gallbladder in this image. Here are some other common variations with regard to shape of the gallbladder. It can often be found folded on itself like this. If the fold occurs at the neck, we call it a Hartmann's pouch, but when it occurs apically, we term it a pharyngean cap. It can also be dramatically folded or septated like this. Once your longitudinal sweep is complete, the probe is rotated 90 degrees to the patient's right to obtain the short axis view of the liver and gallbladder. Here, the gallbladder should appear circular. Ensure a complete sweep through the entire length of the gallbladder. Note that since the gallbladder is not a fixed structure, the longitudinal and transverse planes of the organ may not align with the longitudinal and transverse planes of the body perfectly. So once you identify the gallbladder in one plane, you may need to rotate clockwise or counterclockwise slightly to ensure that the gallbladder is its longest in the longitudinal and its most circular in the transverse. Here are a couple of examples of the gallbladder in transverse. In the left image here, we can see that the gallbladder wall appears a little bit thickened. We'll talk more about that in a bit. Also may have a bit of pericholecistic fluid. And then here is an example of a gallbladder with a hyperechoic structure inside of it. It appears to be a gallbladder polyp given the lack of posterior shadowing. And then in the bottom right, we have another hyperechoic structure inside this transverse gallbladder, which may or may not be a septation. Let's move on to the X-7 approach. So unlike the subcostal sweep, which seeks the gallbladder from under the costal margin, the X-7 approach is an intercostal approach in which the probe is initially placed about 7 centimeters rightward of the xiphoid process, the X, and aims between the ribs to find the gallbladder. Once found, the gallbladder is again evaluated with fans through its longitudinal and transverse planes. Finally, let's cover flatten the probe. So the final technique essentially attempts to locate the gallbladder in a coronal plane by flattening the probe as much as possible into the abdominal wall subcostally. Once identified, the probe is rotated as needed to elongate and shorten the gallbladder into longitudinal and transverse planes. In reality, a combination of all of these approaches is generally used when someone is looking for the gallbladder. Even with all of these different techniques, it can be elusive. So here are a few tips to improve your technique. First and foremost, confirm with the patient that they have not had previous biliary surgery or cholecystectomy. Often patients don't know or can't tell you, but other times they can. And I've definitely made this mistake in the past. You'll waste a lot of time and feel pretty silly when the patient is able to offer that information. Second, place the patient in the left lateral decubitus position to allow gravity to help you by bringing the gallbladder out from under the liver and towards the abdominal wall. Also, if the patient can cooperate, ask them to take a large inhale and hold. This will contract the diaphragm and push the gallbladder inferiorly out from under the rib cage. Occasionally, the gallbladder is difficult to differentiate from the liver vasculature. Applying some color flow or color Doppler to the image will highlight the vessels, which have flow, but not the gallbladder, which does not. A patient who has eaten recently may have a contracted gallbladder, which can be more difficult to find, so allowing a period of NPO may allow the gallbladder to refill and become more readily identifiable. Finally, make sure your patient's pain is well controlled because this will allow you to have a better examination. As we discussed in the anatomy review, the gallbladder sits in close proximity to the duodenum. Here is an image of the duodenum in transverse. It is frequently mistaken as the gallbladder. Similarly, large renal cysts of the right kidney are anechoic structures that sit in the right upper quadrant as well. So make sure to evaluate any structure you believe is the gallbladder in two views to determine the presence of landmarks like the median lobar fissure and the portal triad to confirm you are indeed looking at the gallbladder. Additionally, in the case of the duodenum, if you observe it for a period of time, you will often see some bile gas peristalse through the lumen, which you should not see in the gallbladder. So let's move on to our 5 binary biliary questions. These are really the point of care questions that we ask when we put the probe on the patient for this purpose. Once you've found the gallbladder, you're going to ask each of these questions to yourself. Are there gallstones? Is there gallbladder wall thickening? Is there pericholecistic fluid? Is there common bile duct distension? Is there a sonographic Murphy sign? Not surprisingly, affirmative answers to these questions suggest the presence of cholecystitis, choledocholithiasis, or ascending cholangitis, depending on the surrounding clinical and laboratory circumstances. So for the first question, are there gallstones, yes or no? Gallstones will appear as strongly echogenic foci with accompanying posterior shadows. Notably, they form what we call a clean shadow, which you can see here. They're usually mobile, so they will move with the change in position of the patient. Here you can see 2 gallstones with accompanying posterior clean shadows. Here's another longitudinal image of the gallbladder with some dependent stones and posterior shadowing. Sometimes the shadowing is actually easier to spot than the stones. Here is a clip of a gallbladder with a ton of stones. Notice how the stones could easily be missed if the sonographer did not fan through the entire 3D space. Again, more stones with more shadowing. Can you tell what's happening here? This is called the wall echo shadow sign, where the gallbladder is so full of stones that all we can see is the anterior wall of the gallbladder, an echo from the hyperechoic stones, and then shadow. The lumen or interior of the gallbladder is not visible secondary to this shadow. Here is a wall echo shadow sign in the transverse. Here's another variation on something that you might encounter. This is gallbladder sludge. Formation of gallstones tends to happen on a continuum where the actual stone is the end of the continuum, and sludge is kind of the beginning of the crystallization of bile salts, but they haven't really coalesced densely enough to prevent passage of ultrasound waves. So, because ultrasound waves can still pass through sludge, we see some hyperechoic material within the gallbladder, but there is no accompanying shadow seen. Here's some more sludge. What do you think about this image? This is a hyperechoic structure within the gallbladder. So it could be a stone, except we're not seeing any associated shadowing. This is actually a gallbladder polyp. So it remains fixed regardless of the patient's position because, unlike sludge, it's adherent to the gallbladder wall. For comparison, the polyp is again shown on the left, And you can see some stones with shadowing on the right. How about this? This is described as a linear hyperechoic structure within the gallbladder. Again, we see absence of shadow. And this is just an example of a gallbladder fold. Earlier I mentioned when looking for stones, we actually can see the shadow even before we can see the stone often. What do you think about this image? You might suspect an occult stone here because of the shadow that you're seeing. However, as you might remember from your physics session, this is edge artifact. Edge artifact is a black signal which appears to emanate from the edge of curved structures, like the gallbladder or a cyst. This occurs because the curved surface of the gallbladder reflects ultrasound waves in a direction other than back to the crystal that emitted the waves. Without return of the echo, a black signal is produced. Edge artifact is important because it is often confused for shadow. Here's some shadow just for comparison. Both artifacts are related to how ultrasound waves are reflected back to the probe, but shadowing is a signal void behind a physical structure which is highly absorptive or reflective, like a bone or a stone. Moving your probe, like fanning or rocking slightly, should demonstrate movement or resolution of your edge artifact, which will help you differentiate it from a true shadow. Moving on to binary biliary question number 2, is there a gallbladder wall thickening? Here's an example of a normal gallbladder. A normal gallbladder is usually less than 7 to 8 centimeters long and less than 4 centimeters in diameter. In about 97% of patients, a normal wall is also less than 3 millimeters, less than 3 millimeters. It is important to measure the gallbladder wall thickness along the anterior or superficial wall rather than the posterior due to an artifact we covered in the physics session called Posterior Acoustic Enhancement. This is an increase in echo behind fluid-filled structures like the bladder, gallbladder, cysts, etc. Posterior acoustic enhancement results from the relative ease of ultrasound wave movement through the fluid-filled structure, which is low impedance, and its interaction with the attenuating posterior wall of the structure. The result is an appearance of increased gain behind fluid-filled structures and a false increase in the wall thickness and the posterior wall. While shadowing is a loss of signal posterior to high impedance structures, posterior acoustic enhancement is an increase in signal posterior to low impedance structures. Here is a transverse image of a normal gallbladder. Again, we see the edge artifact on the left side of the curved wall of the gallbladder, and posterior acoustic enhancement is again present posterior to the fluid-filled gallbladder. Ideally, you will place the calipers on either side of the hyperechoic anterior wall. Here, the normal thickness is 0.29 centimeters. Here's an example of a stone with some posterior shadowing and a thickened anterior gallbladder wall, which is at approximately 4 to 5 millimeters. Make sure that you are measuring perpendicular to the wall of the gallbladder. Here is another example of a thickened wall on the right as we compare it to a normal wall on the left. Here is another thickened wall in a transverse gallbladder with some layering stones. This anterior wall measures 5.7 millimeters. Additionally, this is an interesting image because you can simultaneously see the shadowing directly posterior to the stones and the posterior acoustic enhancement on either side. Finally, you can see edge artifact just off the lateral aspect of the posterior acoustic enhancement. Wall thickness is the most sensitive finding of cholecystitis on ultrasound. Using a cutoff of 3 millimeters, sensitivity may approach 100%. Thus, the lack of wall thickening argues strongly against a diagnosis of calculus cholecystitis. However, this sensitivity is accompanied by the drawback of being very nonspecific. Thickened walls can be caused by many other factors, which are commonly found among critically ill patients. So aside from acute or chronic cholecystitis, these conditions listed here can also cause a false positive thickened gallbladder wall. The third of our binary biliary questions is there pericholecystic fluid? So a normal gallbladder sits snugly up against the liver. The inside of the gallbladder is anechoic, while the liver is of its typical echo texture. When looking for pericholecystic fluid, you want to trace the wall of the gallbladder with your eyes, looking for any anechoic areas outside of the gallbladder. This would represent pericholecystic fluid. And here's an example. Here's another example of a longitudinal gallbladder with pericholecystic fluid. It appears thickened as well. And here's an example of a transverse gallbladder with some pericholecystic fluid. Finally, another example of a gallbladder with a thickened wall, some sludge, and some pericholecystic fluid. Please be aware that just like with gallbladder wall thickening, conditions other than cholecystitis can cause pericholecystic fluid. Most commonly, you may see patients with ascites with pericholecystic fluid without an associated cholecystitis. Our fourth binary biliary question. Is there a common bile duct distension? So distension of the common bile duct would suggest that a stone is lodged within that duct and causing proximal dilation. Identifying the common bile duct can be a bit tricky, but when viewing the gallbladder in the longitudinal, you can use the main lobar fissure to point from the gallbladder to the portal triad. Recall the portal triad is made up of the portal vein, hepatic artery, and common bile duct. All tend to have echogenic walls and sit in a formation reminiscent of Mickey Mouse. So if your probe marker is to the patient's right, the CBD should be Mickey's right ear, or to the left on your screen. If you're unsure of which structure in the triad is the CBD, you can apply color Doppler to the image. Only the portal vein and hepatic artery will have flow. Although the CBD technically has flow, the flow is so slow that it's not perceptible on ultrasound. Here you can see that the Mickey Mouse is not as clear as the last example, but the color flow allows you to determine which hypo or anechoic circular structure is the CBD. Here is another example. Now, you might be unsure which of these structures is the gallbladder. Is it this one or this one? But if you follow the linear hyperechoic structure that is the MLF, you will see the portal triad or the Mickey Mouse at the end. You have your hepatic artery, your CBD, the right ear of Mickey Mouse or patient's right, so on the left side of your screen. And then your portal vein is his face. There's your IVC. Here's an example of a folded gallbladder where the neck is kind of serpentine. The MLF is super short but still bright white and points to the portal triad. And once you can identify the CBD, you're going to measure it from inner wall to inner wall. A normal CBD should be less than 6 millimeters. Though we give seniors an additional millimeter per decade. So for a patient who is 82, they would be allowed an 8 millimeter CBD. Another example of the MLF is here. You can see that nice hyperechoic line from the gallbladder pointing towards a Mickey Mouse shaped structure. Now here is an example of Cbd dilation. So the gallbladder can be seen to the top and right of the screen, and the color flow gate is placed over the portal triad where we can see the hepatic artery and the portal vein light up with flow. The dilated CBD is without flow, and the measurement here is well above normal at 1.89 centimeters. You can see that in the bottom left corner. Here's another example of color flow over the portal triad. Normally, when we see the Mickey Mouse sign, the gallbladder is in the longitudinal and the triad is being cut in cross-section or transverse. Here we're actually seeing the triad in longitudinal. So instead of a Mickey Mouse, we're seeing more of a train track pattern where the CBD and portal vein run parallel to each other. The portal vein has color flow here, and the CBD has a large stone visibly lodged within it. Sometimes this is also called the double barrel sign. Here you can see the portal vein and CBD in longitudinal, with a CBD stone present with posterior shadowing. On to the last binary biliary question: is there a sonographic Murphy sign? So a sonographic Murphy sign is elicited in a similar fashion as the traditional Murphy sign, except with the sonographic Murphys, the probe is placed in the right upper quadrant and the gallbladder is visualized with the transducer prior to applying pressure to the area. With the gallbladder in view, gentle but firm pressure is applied with the probe. If an arrest of inspiration is noted on application of this pressure, the sign is considered present. If it is present, this is one of the more specific findings for cholecystitis. So here are some take-home points for hepatobiliary POCUS that I want to just review quickly before we move on to practicing some of these skills with some cases. So the normal liver is homogeneous. If we're seeing anything that doesn't look like a smooth, kind of medium echo texture structure, there may be a problem. Portal veins have echogenic walls. Hepatic veins do not. The normal gallbladder wall thickness is 3 millimeters or less. Gallbladder wall thickness is measured using the anterior wall due to that posterior acoustic enhancement. A normal CBD diameter, remember inner wall to inner wall, is 6 millimeters with an additional millimeter per decade allowed to patients over 60. And then calculus cholecystitis should be suspected in patients with gallstones plus a thickened gallbladder wall, pericholecistic fluid, Cbd dilation, or a sonographic Murphy sign. So before we conclude our talk about hepatobiliary ultrasound, let's go over a few cases to help apply and stretch your new knowledge. Our first case is a 75-year-old female in the MICU. She's intubated for the last 6 days for a multifocal pneumonia. On hospital day 6, she is noted to have an increasing white count, tachycardia, and fever. So the blood cultures that you had drawn at presentation demonstrates that the patient's gram-positive sepsis is sensitive to her current antibiotic regimen. However, your senior resident wants to search for new causes of her leukocytosis and fever and asks you to perform a right upper quadrant sono. Here's an image representative of your study. What do you tell your senior? So the real answer is that first, whenever you're asked to make a judgment based on a single ultrasound image, always ask to see more images. For time's sake, I'm going to tell you that you performed a very thorough evaluation of the patient's gallbladder and you found no stones. The rest of her exam is consistent with what you can see right here. So you might report to your senior, I see a thickened gallbladder wall with pericholecistic fluid. This is a case of acalculous cholecystitis, meaning the cholecystitis occurs absent any gallstones. This is an entity often observed in critically ill ICU level patients who may or may not be on TPN. It is thought that the lack of enteral nutrition and hypoperfusion creates this hypotonic, dilated gallbladder. Distension of the gallbladder increases the gallbladder wall tension, further impairing the perfusion of the gallbladder, which can lead to necrosis and perforation of the gallbladder. Superinfection with enteric bacteria may occur, but a lot of these cases occur without bacterial infection. This is important because acalculous cholecystitis often goes unrecognized initially because of severe illness, intubation, and sedation. This can lead to a high rate of progression to gallbladder necrosis and perforation, and this also has associated with a very high mortality rate, much more than regular cholecystitis. This demands emergent intervention, whether that be surgical, endoscopic, or percutaneous. Case number 2. You have a 45-year-old female with past medical history of diabetes, hypertension, psoriasis, and now right upper quadrant pain. Your right upper quadrant ultrasound demonstrates this. What do you think? So there is a large hyperechoic stone in the gallbladder with posterior shadowing. You can see that on the right side of the gallbladder here. Additionally, there appears to be a hyperechoic anterior wall of the gallbladder with an obscured image posterior to this wall. There is some trace pericholecistic fluid. This is actually a case of emphysematous cholecystitis. There is gas in the anterior wall caused by infection with gas-producing organisms. Here we are seeing actually the dirty shadowing caused by gas over the left aspect of the gallbladder, while we can see clean shadowing posterior to the stone. Recall the distinction we made earlier during our physics talk. A dirty shadow is a type of shadowing associated with gas. For example, on the left here, a loop of bile is coming close to the gallbladder and causing some dirty shadowing. Dirty shadowing is kind of this hyperechoic echo superficially, and then a gradual transition to anechoic findings, almost like smeared pencil. Contrast that with the clean shadowing seen on the right behind some stones. They're very hyperechoic stones, and then there's a harsh transition to anechoic shadow deep to it. Emphysematous cholecystitis is an infrequent but insidious and rapidly progressive form of acute cholecystitis. It also is associated with a very high mortality in the range of 15 to 25%. Case number 3. We have a 32-year-old medical student presenting with fever and right upper quadrant pain. Your right upper quadrant ultrasound demonstrates this image. What do you think? So this is a coronal image of the right upper quadrant. And as we discussed, the liver is normally homogeneous, very homogeneous. But here we have a large circular hypoechoic mass-like structure in the parenchyma. On further questioning, the medical student has just returned from India about 3 weeks ago, where he was involved in a medical mission trip. While he was there, he did have a few days of diarrhea. This is an example of an amoebic liver abscess. It's the most common extraintestinal manifestation of amoebiasis and is one mimic of acute cholecystitis. Here's an example of a pyogenic liver abscess. Note it is different from an amoebic liver abscess in that it is loculated and multifocal. These are often secondary to polymicrobial infections and require drainage and broad-spectrum antibiotics. Mortality of these are around 10%. In preparing for this talk, I found this really nice schematic to help conceptualize an approach to biliary ultrasound, which you can use to review. But also I wanted to give you a few great foam links for you to get more practice and case exposure. Additionally, I've got a few little Quizlet type of slides at the end of this talk, and I will send you the PDF version so that all of these links will be live. Please don't hesitate to contact me if you have any questions or concerns, if anything I said was not clear, and I look forward to meeting you all shortly at our hands-on sessions. Thank you and have a great day.